The COVID pandemic has been quite a major impact on a lot of our clinical trial operations. Specifically, at MD Anderson, we get a lot of referrals. About 70% of our patients actually come from outside of the greater Houston area. And although at this time our clinical trials are still open and we are still enrolling patients, it has been difficult for patients to travel. And so we are seeing a significant drop in the number of patients who are able to make it. One of the big changes that has occurred is that, especially for patients who are already on oral therapy, so this includes FLT3 inhibitors, IDH inhibitors, venetoclax-based therapies, we have gotten permission both from the MD Anderson IRB as well as from the US FDA to be able to ship those treatments out to the patients who are living in other states. And what we're doing now is working a lot with the local hematologist oncologists. So for the end of cycle visit, where they would have traditionally come to MD Anderson, seen by me, have exam by me, get a new prescription, start the next cycle, we're actually having them do all of that with their local hematologist oncologist and getting the documentation of that clinical visit, examination, labs, and actually that's then reviewed by the PI, signed and put into the regulatory binder. And so we're basically kind of using the local hematologist oncologist for on-trial documentation, which is quite unique. It's something we have not done. But, as they say, necessity is the mother of all invention. And so it's actually been working, touch wood, quite smoothly. And we're very happy for the support and collaboration we're able to get from our local hematologist oncologist. And I think this may actually even translate after the COVID era into a better collegiality, collaboration, and kind of a two-way communication between the local hematologist oncologist and the large cancer centers. So there may be some peripheral positive impact that comes out of this COVID scenario. Now, the other thing that we have not yet done at MD Anderson, and we have been fortunate and hopefully will continue in this way, where we have not had a huge number of patients. It has been controlled. We have not seen the kind of surge that has been seen in New York, Massachusetts, other areas in the US. So we have not changed our frontline induction approaches, whether it's for AML or for ALL. One thing we do routinely is we do a COVID testing before starting any induction therapy for AML, ALL, or before starting any consolidation therapy, or before going for stem cell transplant or CAR T. And if the patient were positive, then we would either defer the treatment if that were possible, or we may consider shifting to a moderate or lower intensity induction therapy instead of doing the traditional high dose induction, and then maybe in the future consider going back to the high dose induction if it were needed. But now in New York and other areas where I have a lot of friends and colleagues in the large cancer centers that we've been in close discussions with, they actually have been considering more and more moving to moderate or lower intensity therapies across the board. So for example, in acute myeloid leukemia, even in younger patients, there is more use of HMA with venetoclax, or HMA with FLT3 inhibitor, or FLT3 inhibitor plus venetoclax, which is a complete oral regimen. And this is because going to the hospital, being in the outpatient or inpatient setting in a place like New York is extremely dangerous. So even though these may not be the ideal upfront therapies, they may be better than doing nothing and better than doing anything inpatient, which I think is what has to be done. We have to make the decisions based on the best we can do at that time for the patient. But I think this may actually provide us a wealth of new data on using these novel combinations or these novel regimens in different settings from where they're approved, and may actually help us in the future even consider some of these for our younger patients if they do show equivalent or similar efficacy. So I think, we're trying to do as much as we can. I would say that all our acute leukemia patients are still getting treated in some way or the other. And we're looking to hopefully see the end of this soon. The clinical trials and enrollment, unfortunately, are going to be impacted. It is going to take us a few months to recover from this. But hopefully when it's all over, we will be able to recruit and reopen these trials rapidly and not lose too much in the way of science and data for treatment of acute leukemia. Thank you.